supraventricular means above the ventricles. That's the whole name right there. Somewhere above the ventricles, an electrical signal gets caught in a loop and it starts firing over and over again, way faster than your SA node ever would. Okay. So the SA node is supposed to be in charge. In SVT, it gets outvoted. Now the heart is running 150 to 220 beats per minute. Here's the part that actually matters, though, regarding your exam. The ventricles fill during the pause between the beats. Take away the pause, and you're going to take away that filling. A heart that never fills has nothing to pump out, right? So a rhythm that looks just like a fast heart rate is really a cardiac output problem waiting to happen. So there's 4 things on the strip, and every single one of them is going to tell you something. So narrow QRS means the signal came down the normal wiring, which means it started above the ventricles. If that QRS were wide, the ventricles would be running the show, and this would be a completely different rhythm. Regular means single loop firing over and over, not chaos. And those P waves are not actually missing. The atria are still beating. They're just beating so fast that the P wave lands right on top of the T wave from the beat before and hides inside of it. Narrow, regular, fast, no visible P, that's going to be your rhythm. For causes and triggers, we're going to sort these into 2 piles so you never have to memorize them. Pile 1 is anything that revs the system up. We have our patients that are amped up. So we're thinking caffeine, nicotine, cocaine, any other type of stimulants, plus a sympathetic surge from like stress, anxiety, fever, or low oxygen. All of those speed up the conduction through the AV node. And a faster AV node is exactly what a reentry loop needs to kind of get going. So pile 2 is anything that damages normal pacemaker control. So heart disease, electrolyte imbalances, and digoxin toxicity. On the exam, the trigger is usually sitting in the backstory, not in the question itself. So the college student that's pulling an all-nighter and drinking energy drinks is going to be your cue. So this slide is going to be your whole test. So a patient at 188 who is talking with you with a blood pressure of 112/68 is stable. A patient who has a pulse of 188, who is gray, they're hypotensive, they're clutching their chest, they're sleepy, they're unstable. Same rate, completely different answer, okay? So stable means that the patient is still perfusing. Blood is still reaching the brain, the heart, the kidneys. Unstable means that it's not, and you can see it in the blood pressure. You can see the chest pain, or they can tell you about the chest pain, the lungs filling up, or by the level of consciousness. So do not let your numbers pick your answer just by saying that this is SVT. Ask, what does my patient look like? That is what is going to pick your answer. So right now we are going to be talking about our stable patient. So we're going to start low tech and we're going to work our way up. So we start with oxygen, monitoring, IV access. Remember, at this point, we have time. 12 lead first, because you need to prove that this is SVT and not a wide complex rhythm before you treat it, okay? And then we're going to do vagal maneuvers. We could have them bear down like they're having a bowel movement, have them cough, ice to the face. That's going to stimulate the vagus nerve. The vagus nerve is going to slow the AV node, and the slowing of the AV node can break the loop. If that fails, we're going to give adenosine 6 milligrams, and it has to be rapid push. The half-life is only 10 seconds. We give it over 1 to 2 seconds, okay? So we are going to push it with a rapid, normal saline flush right after it, because the adenosine is going to be gone in seconds. It works briefly by stopping the AV node so the SA node can take back over. Warn your patient first. They're going to feel horrible. They're going to have impending doom. They can have horrible flushing, and it's only going to last for a few seconds. If you don't warn them, they're going to think that they're dying. If 6 does not work, we repeat the process by administering 12 milligrams of adenosine. After that, you're going to move to a beta blocker or calcium channel blocker for more longer rate control. So unstable is going to change everything. You are no longer coaching anybody about anything. We have our unstable patient. So no coaching right now to bear down, okay? We have rapid response, oxygen, pads to the chest. Rapid response, oxygen, pads to the chest. And you are going to be setting up for synchronized cardioversion. Synchronized here is going to be the word that matters. The machine watches for the R wave and times it to the shock to land on it, okay? So the shock cannot land on the T wave. A shock that lands on the T wave is going to send your patient into VFib. So now you have a code instead of a cardioversion. Sedate them if you have time because this does hurt. But if they are crashing in front of you, perfusion is going to beat comfort and we will proceed with the shock. After it converts, you're looking at airway, rhythm, blood pressure, and then you're hunting those triggers because if the caffeine or the electrolyte is the problem and it's still there, so is the SVT. So now I want to talk about the 4 drugs. Adenosine is going to be your first line. It is the strangest drug you are going to ever push, okay? Because it stops your heart for a second on purpose so the SA node can grab the wheel back, okay? So it can take control again. You will see a flat line on the monitor and that is going to be expected. We're going to warn the patient, we're going to push it fast, and we're going to flush it even faster. Amiodarone is going to be the backup if adenosine does not hold for our patient. We want to watch the pressure because it does drop patients. Diltiazem and metoprolol slow the AV node for ongoing control, and both of them carry the same hold parameters. Systolic under 90 or heart rate under 60, you're going to hold and you're going to call the provider. Verapamil is going to be the other calcium channel blocker, the same as hypotension and the same hypotension, the same bradycardia risk, plus constipation over time. We want to notice this pattern, okay? Everything here stops at the AV node or slows it down. Excellent job on your SVT review today. And remember, you will pass your boards.